Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the brand new season of Optometry series. So, this is third season of Optometry series. In this season, we're dealing with the instruments of optometry and ophthalmology. I'm very happy to welcome my team members, Ms. Anshika ma'am. Hi ma'am, thank you so much for joining. And here we have a new teammate, Ms. Nancy. Hi Nancy, thank you so much for joining.
Hi.
So, Anshi ma'am, over to you. So actually, this particular episode, we're dealing with visual field testing. So who you roped in as the moderator for the day, ma'am?
So yes, moving on to the third episode of Optometry series, we are going to have visual fields testing and instrumentation. Today we have Miss Harshada with us. She will be the moderator for the session and she is a very good faculty. She is currently working at Goa Medical College. So we'll have her intro and then we'll start up with the session. Over to the MC.
I call her MC for the day, Ms. Roshan, to start introducing the moderator for the day.
Good evening, everyone. I'm Roshan Samira, a third year Bachelor of Optometry student at Dr. Agarwal's Institute of Optometry. It's my great pleasure to welcome our moderator, Ms. Harshada Narvekar. Harshada ma'am completed her Bachelor of Optometry from Goa Medical College and Hospital and her Master of Optometry from the Manipal Academy of Higher Education. She is currently pursuing her PhD at Manipal Academy and is working as a lecturer in optometry at Goa Medical College and Hospital. Ma'am has over years of experience in undergraduate optometry teaching and clinical practice. Her area of specialization is low vision rehabilitation, and her areas of interest include visual functions, geriatric vision, community optometry, and optometry education. Ma'am has extensive research experience and is the author of several original research articles published in peer-reviewed international journals. She is passionate about contributing to the advancement of optometry through research and education. On behalf of Dr. Agarwal's Institute of Optometry, we are truly delighted to have you with us, ma'am. A very warm welcome. Now, it is my pleasure to introduce our presenter, Ms. Saara Arsheen, a third year Bachelor of Optometry student and a member from research team at Dr. Agarwal's Institute of Optometry. Saara Arsheen, please begin your presentation. Thank you.
Thank you, Roshan. Am I audible?
Yes, you're audible, Sarah.
Good afternoon to one and all present here. Myself, Saara, a third year Bachelor's of Optometry student from Dr. Agarwal's Institute of Optometry. Today, I'll be talking about the visual field testing methods and its instrumentations. So, what is visual field? It is an extent of area which is visible to any individual when he or she fixates at one particular direction. Harry Tranquer defined it as an island of vision surrounded by a sea of blindness, also known as the hill of vision, considering a three-dimensional aspect. The area with the highest retinal sensitivity is basically the fovea, also known as the apex of the hill. The sensitivity decreases as we move towards the peripheral retina. The apex or tip corresponds to the fovea, which has the highest sensitivity. The base of the cone corresponds to the area of lowest sensitivity. Visual acuity is usually the sharpest at the top of the hill and gradually decreases towards the periphery. This image basically is the visual field expansion of the monocular eye. As we can see, the visual field extends up to an angle of 60 degree superiorly and both medially. And it extends up to an angle of 80 degree inferiorly and 100 degree temporally. And it has a central 30 degree field. This is the image of the visual field using the binocular vision. We can see that the binocular visual field extends up to an angle of temporally 200 degree, which includes both right eye temporal and left eye temporal field. And it overlaps up to an angle of 120 degree centrally. What basically is blind spot? The blind spot is located between 10 degree to 20 degree temporally to the point of fixation. It is where the optic disc is present. The blind spot corresponds to the optic disc where there is no photoreceptors and hence no vision is perceived from this area. Measurement of visual field or perimetry. The measurements of the retina's sensitivity to light is shown at a given location in the visual field printout. The sensitivity of the retina of a healthy individual is highest at the fovea, then reduces towards the periphery. The intensity of the light stimulus is measured in apostille. However, apostille and retinal sensitivity are inversely proportional to each other. Also, the human eye responds to a wide angle of apostilles. Therefore, the sensitivity of light is measured in decibels. Decibel is the logarithmic representation of the intensity of the light stimulus. Basically, the intensity of the light stimulus is measured with decibels. It is an adaptation of the Weber-Fechner law, which explains that sensation increases as the logarithm of the stimulus. Decibel has a direct correlation to the sensitivity of the retina. 0 decibels means which has the brightest light stimulus, and 50 decibel means the dimmest stimulus. If 0 decibel stimulus is not seen, that denotes an absolute scotoma. Threshold. It is the intensity of the light stimulus, which is when presented at a particular location, is detected by the corresponding retinal points at least 50% of that point. The threshold is used by the staircase method 4-2-1. As we know, when there are two ways to use this method. Initially, when the stimulus is not seen, the intensity of the stimulus is increased in 4 decibels until it is seen. Then once visible, it is again reduced in steps of 2 decibels until it is again not visible. Then the decibel is again fine-tuned and increased by 1 decibel until it is visualized again. The final decibel reading is the threshold. Perimetry. Perimetry is a critical diagnostic tool for detecting and evaluating the visual field defects, playing a key role in diagnosing and monitoring various glaucoma progressions. Perimetry is the systemic measurement of visual field function. There are two types of perimetry, kinetic and static. What basically is kinetic perimetry? During this kinetic perimetry procedure, the examiner actively performs the test by moving the target on an arc, and the patient responds by localizing the target when it enters into the patient's visual field. In this test, the intensity of the target remains same, whereas the color or size of the stimulus can vary. So this test is useful in assessing two-dimensional extent of the visual field. The commonly used kinetic perimeter is the Goldman perimeter. Next comes the static perimetry. This test is automated. The machine presents a stimulus of a particular size but with varying intensity at various locations. The patient responds by pressing a button when they visualize the particular stimulus. Basically, the examiner provides a stimulus and the patient has to respond once they visualize that particular stimulus. This confirms that the patient can see that particular stimulus. The size is constant for one particular test but can be changed between tests. This test measures the depth of the defect at various locations in the visual field. The commonly used static perimeters are the Humphrey and Octopus. Strategy. These are the testing algorithms so that the test does not take too long and the patient's fatigue does not affect the results. For example, there is full threshold, CETA threshold, and CETA fast. CETA means Swedish Interactive Thresholding Algorithm Standard. First, I'll be talking about the full threshold. There's nothing but the staircase method. A typical automated strategy is used to present a stimulus of higher than expected intensity, then decrease in steps of 4 decibels, and again increase in steps of 2 decibels until it's seen once more. If the stimulus is not seen initially, then its intensity is increased in steps until seen. Essentially, the threshold is crossed in one direction with large increments and then crossed or fine-tuned so that the results are accurate. This is how basically the full threshold staircasing method is done. Suprathreshold. Suprathreshold perimetry involves testing to check that a subject can see stimulus that would be seen by a normal person of the same age. It basically compares with a normal person's visual field. It enables testing to be carried out rapidly to indicate whether function is grossly normal or not and is usually reserved for screening. Fast algorithms. In recent years, strategies have been developed and introduced with shorter testing times. One of the shorter most testing times are fasting algorithms. It provides efficiency benefits with little or no determinant to testing accuracy. The HFA offers the CETA, which uses a database of normal and glaucomatous fields to estimate the threshold values. and takes responses during the test into account to deliver at one estimate throughout the test. There's just a gist of the types of algorithms used. Full threshold, it tests every point in the test pattern with the staircase method. It is most accurate and comprehensive, longer test time, and higher patient fatigue. Next comes the Sita. It tests all points once, then uses an intelligent algorithm to select the most relevant point for thresholding. Good balance of accuracy and speed is provided, moderate test time, less fatigue than full threshold. Last comes the Sita Fast. It tests only fewer points. Algorithm quickly estimates the thresholds at untested locations. It is the fastest test, shortest test time, and less fatigue when compared to full and theta. These are the types of targets shown. It may be central, small diamond, large diamond, and bottom LED. The most common technologies in visual fields are threshold, the intensity of the stimulus that is perceived 50% of the time it is presented. The threshold sensitivity is highest with the fovea and decreases progressively towards the periphery. At the age of 20 years, the sensitivity decreases by about 1 decibel per 10 years. Fluctuation. It is nothing but the variability in the visual field measurements. Depression. It is nothing but the reduction in the normal sensitivity. Scotoma, as we all know, it is a localized defect or depression in the visual field. Absolute scotoma, it is a field defect that persists when the maximum stimulus of light apparatus is used. That is, when the examiner shows a maximum stimulus and still the patient is unable to analyze it. Relative scotoma, field defect that is present to weaker stimuli but disappears when tested with brighter stimuli. A reduced number of retinal points are evaluated for their sensitivity to shorten the test durations, such as 30/2, 24/2, 10/2. And the macular programs are available on the Humphrey Field Analyzer. First comes the 30-2 test. The 30-2 tests the central 30-degree field of the retina with fovea as fixation. This gives a round printout with 30 degree. The digit 2 in this test denotes the points are not located exactly on the vertical or horizontal midline. Instead, the points are equidistant from this line. This helps to better document the visual fields obeying the horizontal midline and vertical midline. This is how the report of a 30-2 test field analysis looks like. A total of 76 points are tested on the retina, each at a distance of 6 degrees from the other in the 30-2 test. This leaves a bare area between the points. This bare area is a circle with a radius of 3 degrees between any 4 points. This bare area remains unevaluated. Next comes the 24-2 test. The 24-2 test is a subset of 30-2 test, where the outermost points are eliminated, retaining 2 nasal points. This tests 54 points. This may be a better program for older adults as it reduces the time taken. Also, this test reduces the number of false negatives due to the patient's fatigue and other points. Also, the points eliminated from the 30-2 field are not considered when diagnosing glaucoma. The distance between any 2 points remains the same 6 degrees. Last comes the 10-2 test because the distance between 2 points is 6 degrees. Since the distance between the 2 points is 6 degrees, the paracentral scotomas can be missed on the previously spoken 24-2 test and 30-2 test. Therefore, any defect close to the fixation on these programs should be retested with the 20-2 program. The 20-2 provides a higher resolution and highlights these defects. The 10-2 tests the central 10 degree of the retina, consisting of 68 closely points with a distance of 2 degrees between any 2 points. This means that a circle with a radius of 1 degree is the area of the retina that remains unevaluated between any 4 points. Macula program. Is this the central 16 points of the 10-2 program? These points in the macular program are tested twice, and this is depicted as a second numeral in brackets below the points tested. As we can see, they have mentioned in the brackets. The macular program and 10-2 strategy are used to check for split fixation in advanced glaucoma, which may be a predictor for snuff out or loss of vision after trabeculectomy. There is again a recap of the program spoken. 30-2 program, most commonly used. It tests 76 points. Point spacing is about 6 degree. And it is best to detect the early to moderate glaucoma and general visual field defects. 24-2 program is used for screening and follow-up and also for glaucoma progression. 10-2 program, it is ideal for macular and optic nerve diseases, whereas the macular program is useful in detecting age-related macular degeneration, diabetic retinopathy, and various macular diseases. Indications. The visual field testing is practical in various clinical scenarios, including diagnosis and progression of glaucoma, assessment of neurological conditions, documentation of field defect, and assessment of progression of retinal diseases like retinitis pigmentosa, inflammatory conditions like birdshot chorioretinopathy. For the visual disability certificates or even for providing diverse license, the legal definition of blindness can also be given. The evaluation of unexplained vision loss. Interpretation. The automated perimetry report for Humphrey can be divided into 8 zones for ease of understanding. I'll be explaining them in 8 zones. This is how the report actually looks like. Zone 1. The Zone 1 mainly includes about the patient's information, such as the patient's name, date of birth, visual acuity, pupil size, and the refractive correction used during the test. The date of birth must be accurately entered into the system. Otherwise, the patient's data will be compared to the normative database of the wrong age group. Hence, it is very important for the examiner to enter the exact database or it might be misdiagnosed. The patient's pupil size should at least be 2.5 or 3 mm or the same size as the previous field test. This also gives information about the test pattern formed, whether it was 30-2, 24-2, 10-2, or the strategy used such as FAST algorithm, theta, or theta fast. Using the recent most refractive correction of the patient with the appropriate near addition when performed, the test is essential. It nothing means when the perfect refractive correction of the patient must be entered into the system, and if the patient has any addition correction, even that must be mentioned properly. Any refractive error of any one change in one diopter can become a misdiagnosis. Fixation targets in Humphrey field analyzer. The large diamond is used for patients with large central scotoma, whereas the small fixation targets is used to evaluate the foveal threshold. Zone 2. This zone also mentions reliability indices like fixation loss, false positive, and false negative. Fixation losses are calculated using the Hale-Krakow method. In this, the patient is supposed to maintain a fixation on one particular point throughout the test so that it localizes the blind spot. Then the machine randomly presents a stimulus on that point later on the test. Response to that stimulus would mean that the patient has moved the fixation because we all know that the blind spot has no vision, measured as fixation. The presence of more than 20-degree fixation losses indicates poor reliability of the field report, and the other two methods for fixation monitoring are gaze tracking and video monitoring of fixation. So what is false positive? They are the records when the patient responds even without a stimulus is presented. False positives are up to 33-degree are acceptable as per the manufacturer. Excess false positive masks the underlying visual field defect. It becomes difficult for the examiner to visualize other underlying visual field defects. False negatives are recorded when the patient does not respond to the stimulus of higher intensity presented at the same location where previously the patient has responded to a lower intensity stimulus. False negatives of more than 33% suggest poor reliability of the fields per the manufacturer. False negatives affect the reliability less than false positive. A value of more than 35% in advanced diseases and more than 25% in early diseases may significantly affect reliability. An increased duration of the test may also affect the reliability. Zone 3. As we can see, this is the grayscale map. A grayscale graph is a color-coded representation of the retinal sensitivity of the patient that is not used for the final interpretation but is essential for the patient education. The values closer to 0 decibels are illustrated as black points. We can diagnose them as scotomas, whereas points closer to 50 decibels are illustrated as white points. And the points with sensitivity greater than 40 decibels are seen as white scotomas on the grayscale and require careful interpretation. The grayscale is useful when comparing a patient's field during follow-up, and it indicates the progression of a visual field both in extent and depth over time at a glance, given that the reliability indices are within normal limits. Zone 4. This zone basically comprises the total deviation numerical plot and the total deviation probability plot. The total deviation numerical plot indicates the depth of a field defect and compares the patient's decibel values at all the retinal points to the normative data stored in the machine for that particular age. The normative database is calculated by collecting responses from healthy individuals. The upper 95% values are arbitrarily taken as normal, and the lower 5% are considered abnormal. A numerical with no sign on the total deviation numerical plot indicates better retinal sensitivity. This data also calculates the mean and pattern standard deviation indices. Zone 5. This zone basically comprises the pattern deviation numerical plot and the pattern deviation probability plot. There's the numerical plot and there's the pattern deviation probability plot. This demonstrates the presence of localized field defects and their pattern. To calculate the numerical value of the pattern deviation numerical plot, the values on the total numerical plot are first arranged chronologically, and the seventh best point on the data is noted. So these are the values of the numerical plot. They are arranged chronologically, and the seventh best point is taken. And that particular point is deducted from all the values on the total deviation numerical plot. This gives the pattern deviation plot corrected for the generalized depression in retinal sensitivity, highlighting an underlying localized depression in the field. A localized defect or decrease in retinal sensitivity would mean an irregularity or localized depression in the hill of vision with a normal height of the remaining hill of vision. Zone 6. This zone consists of the global indices, which are the mean deviation, pattern standard deviation, visual field index, and p-value. What is mean deviation? It is basically the average of all the values of the total deviation numerical plot. This usually has a negative value. As you can see, the negative values are here. Generalized field defects or advanced glaucoma will have a higher absolute mean deviation index. Pattern deviation. This indicates a deviation in the shape of the hill of vision and has a positive sign. A low value indicates the normal shape of the hill of vision, whereas a higher value indicates the irregular hill of vision. Short-term fluctuation. This is a feature of the field test using the full threshold strategy. Selective 10 retinal points are checked for threshold twice, and the threshold value variability indicates a short-term fluctuation. A value of more than 3 indicates low reliability. Corrected pattern standard deviation. This is the pattern standard deviation value achieved after correcting the SF. P-value. All the indices have a p-value that indicates the probability of that particular finding in a normal population. A p-value of less than 5% indicates a 5% or lesser chance of the index to be of the specific value in a normal population. Visual field index. It is the index that is calculated from the pattern deviation numerical plot and was designed to indicate the amount of ganglion cell loss. Zone 7. This consists of the glaucoma hemified test, GHT. The glaucoma affects the retinal ganglion cells on either side of the horizontal meridian. Therefore, 5 areas with a set of retinal points in each area are tested on both sides of the horizontal meridian and compared. The results are displayed as GHT within normal limits, GHT borderline, and GHT outside normal limits. From this case, we can understand it is given GHT outside normal limits. Zone 8. It is the raw data collected by the machine and consists of a retinal sensitivity of each point tested for that program. A 0 decibel value indicates absolute scotoma. In absolute scotoma, even the brightest stimulus when shown is not perceived by the patient. In relative scotoma, a dimmer stimulus is not visible. After assessing the visual field printout, Anderson criteria helps to diagnose and identify the field defects due to glaucoma changes. So these are the interfacing factors. Stimulus type. A white stimulus can be displayed on a white background, whereas the stimulus size is it can range from 0.0625 mm square to 1 by 16 mm square, whereas the largest is about 64 mm square and subtends an arc of 1.7 degree. Stimulus duration. As we all know, the Humphrey field analyzer extends for 0.2 seconds. Background illumination. The uniform background illumination is 31.4 apostle. These are the instructions once the examiner must explain to the patient. The examiner conducting the test has a significant role to play. The patient should receive a careful explanation of what to do during the test. The examiner must carefully monitor the patient's gaze throughout the test. The examiner should take the perimetry test themselves so that they can share their experience and help the patient better understand it. The patient should be comfortably seated during the exam, and he or she must understand what the stimulus will actually look like and how they need to respond. The results will be reliable if the patient is calm and when taking the test knows it can be passed whenever they want. The field should never be interrupted in isolation. A structure function correlation is always advised. The field defect on the printout should correlate with the changes in the optic nerve or retina. Clinical significance of the visual field analysis. First, we have the field defects indicative of glaucoma. A nasal step representing the horizontal meridian can indicate glaucoma. The blue color is the nasal step. Paracentral scotoma are cluster of low sensitivity points that is 10 degree to 20 degree from the blind spot can also indicate glaucoma. The red color is the paracentral scotoma. It extends up to 10 degree to 20 degree. A cedar scotoma, where the paracentral scotoma reaches the blind spot, can indicate glaucoma. The paracentral scotoma reaches. The cedar scotoma extends in an arcuate shape to reach the horizontal meridian. With the progression of the disease, a rim defect is formed when two arcade scotomas are seen in superior and inferior hemifields. As we can see, the green color is the cedar scotoma and it extends and completely forms as a arcuate shape. When two arcade scotomas together forms the biarcuate scotoma. Later, when the glaucoma progresses severely, this is how the visual field appears for the patient with high glaucoma. They result in tunnel vision. Conditions that may require the visual field testing are glaucoma, retinal diseases like macular degeneration, diabetic retinopathy, etc., optic nerve damage, neurological conditions, unexplained vision loss, headache, multiple sclerosis, reduced visual acuity, retinal detachment, strokes, Graves' disease, and pituitary adenoma. Just for a reference. Okay. So even as we all know, lesions in any part of the visual pathway can result in visual field defect. So when there is a lesion in the left optic nerve, it results in no light perception in the left eye. Any lesion on the chiasm can result in bitemporal hemianopia. Any lesion in the right optic tract can result in incomplete left homonymous hemianopia. Lesions on the left lateral geniculate nucleus can result in right homonymous sectiontanopia, also known as lateral choroidal artery, and the left temporal lobe results in incomplete right homonymous hemianopia. Left parietal lobe results in right homonymous defect, denser inferiorly. And when there is a lesion in the left occipital lobe, it results in right homonymous lower quadrantanopia, and is also known as macular sparing. And the left occipital lobe results in right homonymous upper quadrantanopia. And finally, any lesions in the right occipital lobe with result in left homonymous hemianopia with macular sparing. These are my references. Thank you.
Thank you so much, Saara, for this wonderful detailed presentation that we had now. And I would like to ask Ms. Harshada if she has any points to add on the presentation so that the students and the viewers can get benefited.
Thank you, ma'am. I would first like to congratulate Ms. Saara for such a detailed presentation that she did. She has covered majority of the points wherein She first told basics about what is visual field, how much is the extent. Then she has told about the types of perimetry, and then the static perimetry was covered very much in detail. So yeah, it was very nice presentation.
Thank you, ma'am.
Certain clinical tips that I would like to add. Some of them might have been covered in the presentation, but still I would like to emphasize on them. So as a student, it is important that you understand the step-by-step procedure. So I will majorly focus on the static perimetry, which is usually the most common test that we do in the clinic. So it is always important that you, in case it is a first time, it is a patient who has coming for the visual field for the first time. So just go through the case history, go through the case record of the patient, see whether the patient had a previous experience of going through a visual field test. That would give you some idea like how to proceed. In case the patient is going the visual field test for the first time, then you need to spend little extra time to make the patient understand how to go about the procedure. And it is always beneficial that you give one demo to the patient so that the learning effect that we say in visual field, that is reduced. Because it can happen that sometimes in case the patient is doing the visual field test for the first time, there might be some constriction of the field which you might notice. And if you repeat the test, you might see that the patient performs better. So we need to eliminate that learning curve. The other important thing is you need to be careful when you are entering the patient details, when you are feeding the data into the software. So one of the important factor is age. So as it was covered in the presentation, in the static perimetry, all the patient's sensitivity are compared to the age normative data. So the patient age has to be carefully entered into the software. And sometimes we also like to do a comparison of whether the disease is progressing or not. So ensure that so whatever testing strategy you had used previously, the same sort of strategy is used at the follow-up test also in case you are doing manual comparison. So you also have to take care of that. And another important aspect when you are going through the case record of the patient, make sure that you are checking what is the patient's visual acuity, the refractive error of the patient, and also the lens status. So the common type of stimulus that we use when we are doing the visual field test is the Goldman 3 size. But in case your patient has a very poor visual acuity, for example, if it is a low vision patient, then they might not perform very well with the conventional Goldman 3 size. So in that case, you might like to change to Goldman 4 or Goldman 5 stimulus, which is a bigger size stimulus. The other thing is refractive error. You have to ensure that the patient is wearing their appropriate refractive correction. So when we are doing the HFA test, it will have the accessory of the full aperture trial lens, right? So you have to ensure that you have first done the proper calculation for the appropriate testing distance. So in the HFA, the testing distance that is used is 30 centimeter. So you have to ensure that in case your patient is presbyope or if they are aphakic or pseudophakic, you have provided the appropriate near correction. Also, make sure that the whatever trial lens that you have put, it is appropriately centered in front of the patient eye, and it is as close to the patient eye as possible in order to reduce the rim artifact. So that is another important thing. And the third thing, which I already said, you have to know the patient lens status. So sometimes it may be in our mind that only anybody, say 60 years old, they might be pseudophakic, but it can also happen that a young patient might be aphakic or pseudophakic. So appropriate near correction has to be given. So please make sure that you are going through the case record and know the patient's lens status. Apart from this prerequisite, when you are interpreting the test report, you have to ensure that you have gone through all the reliability indices. So I think majority of the things were already covered in the presentation, but the two factors which are, one is your false positive and false negative. So when it is false positive, there are certain ways you can identify whether your patient is giving too much of false positive. So as one thing is you can directly note from the reliability indices. But there are some other ways. For example, you can look at the grayscale plot, and you might see that it is abnormally white. Okay, we call it as white scotoma. So that is one more way to check whether they are false positive. Another way could be to look at the mean deviation. So the people who have high false positive, you will see that the mean deviation value has come excessively in positive. Okay, whereas in normal report it should be a negative value. So that is another point. So usually why this false positive error happen is that patient might be feeling anxious. They are not able to see the stimulus for a long period of time and they are getting anxious about it and they are just simply pressing the buzzer. So you have to take care that you give them proper advice. So they should not get very anxious when they are responding to the stimulus. And you have to make them understand only if they're able to see the stimulus, then only press the buzzer. So your patient should understand the test very nicely. And the other end is your false negative. So this can usually happen when your patient is too tired, and you can try to eliminate the false negative by giving them frequent breaks and make sure that they are not getting fatigued. Usually when it is a full threshold testing, if you are doing that. So these are the two things. Another point could be your fixation losses. Fixation losses can again happen if your patient is not able to see the stimulus properly. So maybe you can change that by increasing the stimulus size. Another way is another thing could be that maybe the person is not able to see properly through the trial lens that you have put in front of their eye. So they might be having a head tilt or they have slightly changed their head position, which could also lead to fixation losses. So all this factor you need to take into consideration when you are interpreting the test report. And another thing which I would like to add is the common types of artifacts which you get. So one of the common one being a rim artifact. So that can again happen because your trial lens is not appropriately placed in front of the patient eye. Or it could be also because the patient is having a high refractive error, usually very common in people who are wearing a high plus lens. So to avoid that rim artifact, better to do the visual field testing with the help of a contact lens rather than using the trial lens. Yeah, so that would eliminate your rim artifact. So the major focus of the presentation, which I felt was on static perimetry, but I would also like to emphasize that you can, kinetic perimetry is, I feel is equally important. So any patient in whom you cannot do the static perimetry, especially because they have poor vision or they are not able to understand the procedure, or another could be your pediatric age group where they may not be that much comfortable sitting for a long period of time doing the static perimetry. You can always do a kinetic perimetry and you will get some idea about what is the extent of the patient's visual field. And you can again use different size stimulus to know how the isopter is changing. So yes, kinetic perimetry will also give you a little bit idea about the patient's visual field status. Yeah, these are the some points I had. And I would be happy to take any questions.
Thank you so much for those valuable points. We have two questions here with us, ma'am. So if you could like to answer them, we'll be very happy. So the first question is like, how do we differentiate a visual field defect caused by glaucoma from the one caused by a neurological disease with the report? So by looking at the report, we would like to know like how are you supposed to interpret if it's a glaucoma defect or if it's a neurological defect?
Okay. So one of the point I think which was covered by Saara in few of the last slides. So she said something about correlating the structure and function. So when you are interpreting the visual field report, it is not done alone. You always have to see what is happening from the structure point of view, right? And so when you say there are some changes with respect to glaucoma, so glaucoma field defects are very characteristic. They will follow a particular pattern. Whereas any defect which is happening because of some neurological condition, they tend to respect we say the vertical midline. So it could be mostly some sort of hemianopias or chondronopia, whereas glaucoma field defect have altogether different pattern. So one is that you have to always correlate what you are seeing in the visual field report with what you are seeing in the structural aspect. So it could be what changes you are seeing in the fundus, or you can take help of your other complex testing like OCT examination. And the other thing is you should be well aware about what are the different characteristic visual field pattern that you see in different ocular condition. So I think if you know this, it would help you in the interpretation.
Okay. So there's another question we'd like you to answer. So that question is, in case the patient has no visual complaints, in what condition should the clinician order for a perimetry? Like the patient has no visual complaints at all, but if you have to ask for a perimetry, what would be the conditions of that?
So in case the patient is complaining of something where you cannot pinpoint what exactly is the reason, right? So visual acuity might be fine, but
Hmm.
still you are seeing there are some changes maybe in the optic disc, or there is some, what do you can say, there are uh, non-specific visual complaints. Like for example, migraine, there is a severe headache, the patient is complaining, but from the usual testing, which are like your visual acuity, the refraction, it is absolutely insignificant. So maybe in such cases, you would like to have a look at the visual field, and that may give you some idea what exactly is happening.
Thank you so much. So that's it from my end. So I would like to hand this over to Anshika ma'am.
Thank you, Nancy. Sarah, it was a very good presentation, a very detailed one, well presented. And thank you so much, Harshada. You added so many clinical valuable points when one is doing a perimetry and things to keep in mind. On a few more points as we were talking about the instrumentation of Humphrey. So we spoken a lot about Humphrey. So major thing as Sarah already spoke, we have a hemispheric bowl when we are actually using or measuring any visual fields. So the background illumination of the bowl is already almost about 31.5 apostles. And the stimulus duration in Humphrey, it stays for around 200 milliseconds, whereas in octopus, it stays for around 100 to 200 milliseconds. And Sarah already spoke about the threshold strategies for Humphrey. So I would just like to say about octopus that we have something called as a tendency oriented perimeter. That means it will not check every point, but it will check the nearby points and it will give you a comparative analysis of the next nearby point. What could be the decibel value or something. And when we come to fixation monitoring systems in Humphrey and when we're comparing octopus, Humphrey generally uses a high Krakow blind spot monitoring system, and there is also a gaze tracker, whereas in octopus we have a blind spot monitor with an infrared eye tracking. So, and Harshada very clearly explained about fixation losses, false positives, all that, how important they are. Coming to the number of points that we are testing, in Humphrey, we have a 10-2 pattern. It checks around 68 points. 24-2 checks around 52 points. 30-2 checks about 76 points. So similarly, in Octopus, you have different programs, which is like G1, G2, 32, M2. So they also have a central 30-degree covered where they have 59 points. And when they are checking with 32, it has a central 30-degree with 76 points. So whenever we are using any machine, we should be aware about how much area are we testing and what are the points that we are testing, because sometimes it helps us to find out what could be the disease that the patient is actually having. So as Harshada also clearly said, it is very important to look for the report, the false positives and the reliable indices. It is also important to understand what is the size of the target that we have used and which instrument are we using, whether we are using Humphrey or whether we are using Octopus, and what does the instrument basically give us as values. So that would be input from my side. Thank you, Sarah and Harshada, for the detailed evaluation and an explanation about Humphrey. Over to you, Gomati.
Yes, so thank you so much, Anshi ma'am. So that was a great input from Anshi ma'am side also. And Anshi ma'am, once again, thanks for roping in Ashida ma'am. Ashida ma'am, thank you so much for joining us as today's moderator, ma'am.
Yes, thank you so much for inviting me as the moderator. I would say that this is a very nice initiative that students get to have little bit of self-learning, and also since it is in the public domain, I think optometry students from across the world would be able to have some benefit from these videos that you upload. I think it's a great initiative.
Thank you so much, ma'am. Actually, we are hearing nice words like this from for like 2 years now. So this is our third season. We already completed 2 seasons with almost 50 plus episodes, and it is available on YouTube also. We like to ask you, request you also to put your words, words about optometry series to your students also, ma'am.
Yes, sure.
Thank you so much, ma'am.
And
And Nancy, ma'am, and Anshika ma'am, thank you so much once again for your continuous support towards Optometry series. Anshi ma'am, so the announcement for this particular week is the admissions are open for Pan India internship and fellowship courses in Optometry. Anshi ma'am, would you like to tell more about the fellowship courses, ma'am?
Thank you, Gomati. Yes, we are open for fellowship courses. We have a specialized cornea and refractive surgeries fellowship, which is available only in Dr. Agarwal's Institute of Optometry, and it is available for 6 months and 1 year. We also have a pediatric optometry fellowship available for 6 months. Here, the students not only get hands-on on pediatric, but they also attend with ophthals and do a complete workup with the ophthals to understand how a child can be taken care of. And we also have a full-time clinical fellowship available. The new one which is there and people are running towards is the research fellowship, which is there because now research is becoming a boom. So we also have a research fellowship available. So optometry students across, if you are interested in any kind of fellowship and so you want to learn practical or you want to learn research, please do contact us at DAIO. We'll be ready to take you in.
Yes, ma'am. The admission details will be given in the description box. So, dear audience, thank you all for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with all your friends. We'll meet you in the next episode. Thank you all.
thank you.